So hi everyone, my name is Simone Carter. I'm an epidemiologist and I run the social sciences analytics cell in the DRC. And I also lead on integrated multidisciplinary outbreak analytics for UNICEF's public health emergencies team globally. Yeah, I'm just going to take you guys through a bit of what are some of the research tactics in terms of understanding infodemics in vulnerable or at-risk populations, looking at communities which would be potentially unnetworked. So we'll talk a little bit about what are the reflections and decision making in terms of methods and data collection within humanitarian settings, some of the risk factors for individuals or groups acting on health misinformation, and do we really need evidence, and have a little bit of a discussion on that as well. But first, I just want to put a little plug in where this information comes from, where does this experience come from, and what is the CAS. So the Social Sciences Analytics Cell is the first platform cell to provide systematic research in an outbreak. So we came in September 2018, and this happened organically. There was no plot or plan, but we started doing social sciences research, which happens in all outbreaks, but in this way, sitting right next to the epidemiologists and having debate and discussion from day one of what does the epi data look like, what does the social sciences data look like, and vice versa, and how are we influencing each other's analyses. And in February, we have terms of reference, so this is what I was mentioning. We got our first terms of reference signed off by the Minister of Health to allow us to work as a unit. And that allowed us to conduct 58 studies over the 2 years of different lengths, but consistently collecting, analyzing, presenting data at all levels in an integrated way. So looking at larger presentations, which were epidemiology analysis and social sciences integrated together, as well as sometimes separate depending on the questions, etc. What this meant, we ended up building a toolkit for how to do this in future outbreaks. So that was kind of the key. We were seeing this as a good practice. And then COVID happened and the 11th Ebola outbreak happened. And amazingly, through the Minister of Health, these integrated units were set up from day one. So there's no longer a debate, they're just there. So they involve epidemiologists, those analyzing DHIS2, so health services use data, and social sciences data together. We have a global analytics for operations working group, which is based on that kind of platform, which looks at how do we use integrated social sciences evidence in outbreaks. We have different links on the presentation. They're all available to different publications, etc. In terms of our objectives, just so you know how we operate, we have teams on the ground who conduct rapid studies to better understand outbreak dynamics, including the impacts of the outbreak. So we might not look exactly at COVID dynamics, but the impacts of COVID are massive, and we follow this closely. We provide near real-time evidence to inform outbreak response decision-making, so strategies, interventions, where donors put their money, for example, as well. And we support the actors to use the evidence. So the idea isn't to run a study, to bring it back somewhere else and to present it in a big room. The idea is to make sure that the evidence gets to the local health actors, to the NGOs, to the civil society, as well as to the decision makers to say what can be done. We document those actions and we track them over time. So we have a tool that allows us to really see what actions are taken on board by who, by what study. And yes, we can see the percentage by type of recommendation or by commission or cluster, who are the most active in terms of making recommendations and actioning on them. We create a space. I'm just checking, is the chat for me? Oh, I'm too fast. Okay, I'll slow down a little bit. Apologies. So we also create the space for integrated multidisciplinary outbreak analytics. And so that brings together different data sources for an improved understanding of outbreak dynamics. And finally, we look at capacity building. So we work with local national researchers where we do systematic capacity building on qualitative and quantitative research methods, as well as how to present data, how to get data used, etc. And so what is AMOA? I will come to why this all matters for epidemiology. When we look at what is AMOA, so that's Integrated Multidisciplinary Outbreak Analytics. This is kind of an image of how it all looks together. So what you see here is it's just an example of all the different data sources that we look at of the impacts of COVID-19 on community health. So in this case, we look at health services data. So we see on the left the use of health services structures. This is DHS2 data. It's analyzed using an interrupted time series analysis for trends. Then we have epidemiological trends in the outbreak. We look at different reports from healthcare centers as well on their data. We have qualitative monthly reviews with healthcare workers, with women, men, and young women. And so, for example, we might see that there's a decrease in the use of health services. It might be reported during interviews that this is because of financial reasons. And so what we then do is go and see who are all the actors collecting data on markets and costs, and does that actually influence? And we bring that data in as well. We see, oh yeah, okay, so if people are reporting that the factors that drive behavior are related to financial situations, we bring in that data around markets and costs as well. We also then see what's happening in private healthcare facilities, because those might be more expensive. So do those drop even more? Or if they're offering free services like Mary Stopes, who offer free mobile clinics, we see that the increase of their services is actually going up in that graph in the top right. Finally, we do healthcare worker surveys systematically, looking at everything from perception of risk, engagement with communities, feeling willing, able to stop transmission of a disease, and how we monitor this over time and based on their trainings, et cetera, to see how that's improving. And what this does is give us a more holistic understanding when we're working with the Minister of Health to develop response of all of the different dynamics that are happening as a result of an outbreak. So that we're not just trying to look at the one disease itself and stop that, but if we do A, what happens to B, C, D, and E? And how do all of those interact together and we make more integrated decisions? And so when we think about that with epidemiology, you look at these different types of data sources. So we have the epidemiology analysis, we have health services data, we have community or individual perceptions, behaviors, healthcare worker and service provision. We also make sure we plot everything on a timeline. So it's very critical for us to know when borders opened, when schools opened, when a rumor started on a network, for example. When did Muyembe, so this is somebody in the DRC, when did he claim that, you know, if there was a vaccine, it would be tested in the DRC? Those kinds of things can potentially influence trust or eventually influence behavior. So we're making sure that all of those things are well noted on a timeline and we keep track of those. We of course always make sure also to monitor the markets and the prices and movements of population. And we should always have an understanding of context. This stuff is a given, but it's amazing how long we take to go, oh yeah, okay, there's women. Oh yeah, there's groups of motorcyclists here, groups of youth here, etc. So making sure that that's included. But now these three areas, they're really data that we need to understand as well, the dynamics around infodemics. And the way that we ask questions and the way that we get this information, it can really support our understanding of infodemics and of misinformation. And so it's not something that would be separate from you. I see a lot of what you would do is just coming right in, and how do we bring that data together to be a more rich, to have a more rich understanding of outbreak dynamics in general. And so if we're thinking about some reflections on decision making and data collection within humanitarian settings. So so some of the key questions that we want to be thinking about are, of course, what information do we want to know and how really are we going to use it? I think COVID, one of the things that's happened, we might talk about infodemiology, but we want so much information. Everybody wants to collect data. I've never seen so many global perception surveys being run. And my question every time is, what are we actually doing with that data at a granular level? How are people benefiting for it versus how much does it actually cost to run that study? Based on when we first know what information we want, how we're going to use it, then who would actually be the best to provide this information? Is it a representative sample size of across the whole country, or do I need something actually at a community level? Actually, do I need something just by the women in the community, for example? And from that, you would get your sampling method. And it should match what we want to ask, and it should match what we want to do with that data. And this seems really simple, that I'm surprised how much under COVID we have moved to be at big scale data collection, even though what we need are very local, very adapted solutions. So we need to think about how do we ask questions so that there's no bias against populations as well, and we'll talk about that a little bit later. And also, what is representative sampling? I think sometimes we work in outbreaks, we think everything has to be 95% confidence interval, 5% margin of error, it has to be representative, but representative of who matters. And if you need to be able to get at the granular level of a particular health zone, or if you're trying to compare why in one health zone there's a behavior or a rumor or a belief that is not present in the other, you don't necessarily need representative sampling. You need to do some kind of case control and barrier analysis. So just thinking about that before we start making surveys and questions and collecting more data. So some of the kind of common mistakes that we tend to make are, first, we set communities up to be negative. I think we have a very, especially in low income or humanitarian settings, we're already setting them up to be bad. And a really good example, and I will come back to this example a couple of times, is that right now we're asking people, there's a survey going on that says, would you accept the COVAX? Just like that. And if somebody asked me that question without any other information, I would say no. If you have somebody in Congo where we've just had a vaccine trial, absolutely they would say no. So the question actually should be, what is, would you accept a vaccine that has been tried, tested, that is assured, that is safe, etc. And explaining what is the vaccine before we say, would you accept this thing hypothetically? And so we then immediately go, oh, well, they're resistant. We put hypotheticals in front of community members or individuals, and that hypothetical will put them in a negative state, and we respond then with what is almost false information because of the way that we've set up a question. We also don't use a methodology that matches what we need. So again, there's nothing wrong with global perception surveys, but other than those who are making decisions in Europe, how are we using the Facebook surveys or the PERC surveys locally? What I'm finding is often we have really, really big, beautiful data sources at a global level, but they don't support, we cannot use them to influence decision-making in country or in community. So how are we making sure that the methodology is something that is inclusive of the users? So are they involved in the development of the study in a way that will make them use the evidence? So often we cannot use the evidence afterwards because it's too big, because it's not representative enough, because it covers too large a population. It didn't ask 2 or 3 questions correctly because we didn't involve the right people in the study design. And fourthly is that we think we need to know and reach everyone. I think sometimes we have to have sampled everybody. We have to have talked to everybody. It's the same in community engagement, risk communication, community engagement. You don't have to speak to everyone in the community to get a message passed necessarily, or to reach everyone. So understanding really who do we need to reach, for what, when, and why. So when I think about what are the kind of key questions that we want to know about misinformation, and this is based on the last 2 years in outbreaks. One is, do individuals have the right information via a mechanism they trust? I mean, this is so simple, and yet, do we know who are the trusted sources? Does everyone have access to these sources? And do they represent community diversity? Do individuals have all the information that they're looking for, and are their questions answered? So what are the common questions? And this would change potentially weekly. Are they updated over time? Do we monitor these over time? And what modalities are available for providing information, and are these used? So we have the risk communications teams who will set up fantastic feedback mechanisms. The question is, do we respond? But also, do we train response teams with the right answers as well? So what are all the different mechanisms to get that information back out? And then what factors drive behavior? This is something really, really important because our biggest concern is about high risk or bad behavior. And the question is, what are the factors that drive behavior? Is it information? Is it proximity to the disease itself? And what influence does the availability and accessibility have? So what are the environmental and structural factors? I think we spend a lot of time assuming, and I will talk about this a lot, that information equals action, and it doesn't. And that non-action does not mean you didn't know. It might mean you could not, for environmental reasons, for structural reasons, for safety reasons. There are so many reasons why people do not behave a particular way. But there's also everybody who smokes knows you shouldn't smoke and they still smoke. We all eat sugar or drink wine, or there's so many things that are done that we know are maybe not good for us, but we continue to do it. So assuming that information or that a lack of action means that you do not have the information, or that information would immediately make you act differently is false. So maybe those are not the only drivers of behavior. The importance of proximity is also really, really key. When people are closer to a disease, they're more likely to engage in protective factors. So if you are going to ask questions, of course, we need to ask questions sometimes, what to ask instead of asking. So this is just a couple of examples. We say, would you accept the COVAX, the vaccine for COVID? So the problems with this question, and this kills me, and as a plug this week, end of this week, the ACT accelerator groups will come out with key questions that should be, that can be used to understand vaccine, what is required in terms of communication and engagement around a vaccine that do not involve questions like, would you accept a hypothetical vaccine? So they will come out with those. Very exciting. But yeah, so the problems with this question are, it doesn't specify if the vaccine is a trial, if it's safe. It doesn't mention who would provide it. Is it a trusted source? It doesn't address questions around this like unknown vaccine first. And hypotheticals are hard to imagine. So it's also important to remember that many cases, being able to put oneself in a hypothetical also depends on education, background, community, culture. So it's not always the easiest thing to be able to explain and have people respond correctly. The other thing that it doesn't allow you to do is filter the answer of who's experienced COVID. So somebody might be more likely to say, yes, I accept the vaccine if COVID had been in their town or their household or their community versus an area where they had never seen COVID. So those other factors are really important. So the results of asking, would you accept COVAX, are likely to respond no, and communities may be labeled as resistant and badly behaved. And this will immediately change how we engage with communities. One of the things that we saw consistently in Ebola was these posters where it said, accept the vaccine. That was it. A woman with the vaccine saying, accept the vaccine. No explanation on how it worked, on if it was safe. What was incredible is the vaccine wasn't even available for everybody. So we need to be mindful of, it wasn't that communities are bad behaving, we have to tell them accept, accept, accept. Also how we ask questions would matter. So instead we can say, what information do you need to take a vaccine? In general, what information would you like about COVAX? Who would you trust for this information? Who would you trust to provide the COVAX if it was deemed safe and suitable for the populations? So these are just some examples to think about it. And of course, as mentioned, the ACT-A team will come out with this toolkit at the end of the week. So another one is, we ask, can you list 3 symptoms? So we're kind of really big on this, like, okay, can they list information, right? But what happens is it doesn't reflect on what symptoms will result in healthcare seeking. And for some disease, we want people to seek care, and other disease, we want people to stay home, right? We want those differences. We want to understand those nuances. But it also doesn't reflect false symptoms, which could be incorrect. So the results were likely 90% of the population can list 3 symptoms, but this isn't useful in decision making. It doesn't mean that we know what instigates healthcare seeking or how to dispel misinformation about the wrong symptoms. So for example, we can ask instead, what are all the symptoms of Ebola, COVID, etc.? And there you might be able to pick up on symptoms that were listed that are incorrect and address the misinformation. we would also realize that some people might not list at all some of the symptoms that are the most common. And there you would also need to highlight there's a misinformation of what are the symptoms. So for example, in Ebola, the misinformation is very much about Ebola, you bleed from your eyes. If you're not bleeding, it can't be Ebola. And because the posters and everything else had said that, and all the beginning of the survey said, no, everybody knows the symptoms. So why aren't they seeking healthcare? And actually, it's that they didn't know the symptoms that were the most common. The other thing is to understand what symptoms drive healthcare seeking for different age groups, for different categories of individuals. So there's a much more nuanced questions that can help us. So when we think about methods, we want to look at, we had those 3 questions of if individuals have the right information, do they have the information they are looking for? Are their questions answered? What factors drive the behavior, protective or high risk? So we can do mapping of trusted sources, we can do household surveys, qualitative tools. There can be also household surveys for individual information, feedback mechanisms. The reason I put stars there are not all of these are research required. Some of them are just good community engagement. You don't need to do a study to know who are your key and trusted sources and doing a network mapping in a community. That is just good community engagement. So the other thing is if you are going to ask questions, you must also analyze. And things to analyze that are important are the wrong answers. So it's a way of highlighting misinformation without repeating rumors, repeating the misinformation. So for example, I go back to some Ebola examples, 75% could maybe list 3 modes of transmission. So they could say touching a dead body, going to a funeral, touching somebody who is sick. But still 35% listed that Ebola is everywhere. And this is not true. Ebola is not everywhere. It's transmitted by specific routes. And what this meant was there's an misinformation that everywhere you go, you're going to catch Ebola. And that influences behavior and fear. And so by only looking at the 3 positives, we're missing some other information that could be addressed. So how do we better talk about transmission routes? How do we better explain this? If this is a big highlight of misinformation that we could address. The other one was that 90% could list symptoms, could list at least 3 symptoms. So the first month, everybody was like, this is great, everybody knows symptoms. But only 10%, and this was consistent with healthcare workers as well, knew that muscle pain was a common symptom of Ebola. And what we were actually seeing was it was the first symptom to present. And so not knowing this lack of information was a huge issue in terms of healthcare seeking. So the other thing that's really, really critical, it seems so simple, and in 2020, I can't believe we still have to talk about making sure that we have age and sex disaggregated data, but we do. It is not possible to not have data that is disaggregated by gender, by age, but also important to look at things like profession, people who have home professions, informal work, etc. We need to look at the trusted sources of information by groups, and the information preferences by groups as well. So making sure that everything we know, we are aggregating by age and gender. As well, if, as mentioned, possibly per profession, you could look at rural versus urban areas as well, by minimum sex binary and age. So if we were thinking about like risk factors, for what are the risk factors that influence or could influence action on misinformation. I'm going to take you through a little kind of case study example here. So we had 3 misinformations. These were three of the most common misinformations around Ebola. So the first was that Ebola vaccines inject Ebola. The second was that there were 2 vaccines. And the third was that decontaminating your house will spread Ebola. And so these were rumors that were dismissed as rumors, that everybody was like, oh, another rumor. And they were coming up on, so on the left, we have Novetta, who was doing social listening. They were coming up in representative healthcare worker surveys and household surveys that the CAS was conducting in the middle. And they were coming up on IFRC feedback. So what did the evidence really tell us? So first of all, it was present in all groups. It wasn't one particular group. There were adults, adolescents, women, motorbike groups. Everybody was seeing these same rumors. Even healthcare workers were reporting the same. So we were seeing it as well among them. So then it's a question about also going at ourselves and saying, well, what are the facts actually? So the first one is there were 3 vaccines, not 2. So we had 1 vaccine, and in February 2019, they realized that the vaccine had been double dosed. And so actually they were giving a double dose. So technically the same vaccine, but when they changed the dosage, the symptoms, the side effects afterwards changed. So the perception, the rumor that there were 2 vaccines, it wasn't one actually. It was a misunderstanding of something that had actually happened. And the third was the J&J that was brought in. So again, the concept and the rumor that was so easily dismissed was actually somehow based in fact. The second one, we dug deeper about the concept that you will inject Ebola when you get a vaccine. But we have done so many polio campaigns across the world, and the concept of antibodies is really strong. And so the idea that you get an injection of the disease itself was present. And so the concept of this is how you do polio, it must be the same. So this is Ebola, was what was being interpreted. But instead we were dismissing, going, no, that's a rumor, rather than addressing and dialoguing with why that came out and actually really smart. Yes, this is how vaccines work. Let us explain it to you. And finally, on the decontamination, what happened was we would decontaminate within 48 hours, and then there's an incubation period of 21 days. So if somebody was going to fall sick, they are most likely to do so after the decontamination has happened. So these kinds of things, we say they're rumors, we dismiss them, we call them misinformation, but actually what they required is a greater dialogue with communities and a deeper capacity of response teams to explain. And I think the hardest part is that the response teams were not skilled enough to explain and address these. They were only able to dismiss them and say, no, just accept what we're telling you. Versus having things like videos that explain how vaccines work, videos explain what a trial is, what a phase 4 trial is, what different types, what other diseases have more than one vaccine, etc. So did groups act on misinformation? Individuals and communities who were less physically, emotionally close to disease, so or felt that they were not engaged, they were more likely to trust misinformation, refuse vaccines, and refuse decontamination. However, individuals who had experienced the disease either in their family or their neighborhood firsthand, so they were more close, there's a greater proximity, or who had felt engaged with the response were more likely to ignore the misinformation and accept vaccines and decontamination. So the solutions that work the most beyond proximity, which is something we have to be really mindful of, especially in sub-Saharan Africa, where, for example, COVID is not something that is a daily issue. We have much more problematic diseases and cause of death here right now. But some of the solutions that did work were more detailed, clear communication information from trusted sources using videos, but making sure that these were available, making sure that the trusted sources actually could answer questions on how vaccines work. Making sure that all of the teams were responsible, so every single team in the response could answer questions. This is a huge challenge. In outbreaks, we put armies on the ground, we say boots on the ground, we send out people to sensitize communities. But often the people that we train get trained once, they get trained quickly, they go out and they never get trained again. And they're not able to answer all the new questions that come up. And so they lose the trust of the communities as well. So how are we setting up mechanisms to ensure that trusted individuals have access to the right information? And I think the other aspect is focusing on what we found that worked was when we used people who had experienced the disease themselves to talk to those who had not. So does misinformation influence action? Not always. And I think that's important to be mindful of. We don't have to already assume that because people might have misinformation that they will act on it. So another example, on the left, we see a graph that asks about the dynamics between healthcare workers and communities during the Ebola response. So what we see is 31 to 61% of respondents reported negative impacts on the relationships with healthcare workers, so an increased distrust. But what we see on the right is the healthcare services used. And actually with free healthcare, in all of the areas where there's free healthcare, the healthcare services increased by 200% and 300%. So while they might have distrusted the services, they were still going. So when we think about the groups of risk factors, so we have individuals who might rely on secondhand data sources or without strong data sources of data. There might be individuals or groups who are excluded or perceived from being excluded from the response. I'm sure there's others that you all know. But does this mean that we need research to determine all of these factors? I don't think so. Often if we're identifying and mapping groups and individuals at a local level, and we're ensuring that their inclusion in the response activities and the interventions, in cases like the DRC, that would mean not prioritizing COVID. That would mean prioritizing measles, malnutrition, malaria, things that are actually facing communities and actually causing death here. It would require providing simple, good community engagement practices that can address correct information via mechanisms, tools, and individuals who can be trusted. That can be enough. In terms of monitoring if people are acting on misinformation, I think one of our biggest failures in attempting to evaluate is using population surveys with hypotheticals. So it scares me a lot to hear global surveys saying, well, X amount of people wouldn't accept a vaccine. And so we already react in a way that is like the population is bad. You know, we're already on the aggressive, but that's actually our own creation of misinformation, our own creation of a question that gave us an answer that does not represent necessarily community realities, but it's the way that we ask the question that created that. And I think that's really important to recognize. The other is about repeating rumors. So did you hear this rumor? And counting how many times the rumor has been heard, but if you repeat it, it's likely to spread. And the last one is, of course, assuming then that information or misinformation will equal action. So what matters most is that the right information is available. It's available to all via the mechanisms which are trusted and our positive behaviors continuing. So those should be the things that we are monitoring over time. So I'm surprised how many times we ask in surveys, what is your preferred mechanism for information? Often medical practitioners. And what is your most received source of information? And it's always radio. And at what point do we use that to go, well, if this is the trusted one, we reinforce the trusted one. And how do we do that? And when do we not need data? So do we need data for everything? Is data required to solve all our problems? No. I think right now we've become a little bit obsessed with data. We want global surveys, we want a global dashboard. There's so many dashboards, and I'd like to know how many of them are being used for real programming to support communities versus how much they cost. So the same way you can have too much information, you can have too much data. So we ourselves cannot cope with all the data that we get, which is why we collect more and new data, because we don't know how to go through all the data that exists and use it for ourselves. So we just go and collect new. And so there really needs to be an effort as well to say, hold on a second, there is so much data. I am now in the DRC. What are the data sources that exist? How do we bring them together and speak to each other? So I'll finish with a couple of things that we can stop doing and some that we can start. So just to remember the questions to ask to understand if we need really more research. First, have we engaged with all the groups represented in the community? Have we sought to speak in local language? Are we using feedback that already exists? Are we responding to that feedback? And have we used existing evidence already? And if we can say yes to all of this and we still have research questions, absolutely, then they're needed. And so 5 things to stop doing. So stop telling people they're misinformed. I think we have a tendency to do that very quickly. A lot of our household surveys indicate that we treat people that they don't know. Stop collecting data, which makes communities look bad. So these hypotheses and presenting data in a way that makes them seem that communities either don't know, they're misinformed, they're already going to be a problem. Like we present it always as if they will be a problem before we start, and where everything is a warning, everything is preparedness for the next worst thing. And I think that kind of language really separates communities or individuals within communities. Stop collecting data which we don't use, and then stop assuming data solves the problem. We need to stop assuming that misinformation is an infodemic, is a rumor, is a bad behavior. Sometimes misinformation, as we showed today, it comes from just a piece of information that was misunderstood, misinterpreted, and we did not have skilled teams to be able to explain it correctly, and we dismissed it as a rumor. And we need to stop assuming that that will all equal action. But we have 6 things, so we have 1 plus, that we can start doing more of. So always making sure that we ask who are our trusted sources and use them and use them and use them. These will change over time, and they shouldn't be identified by leaders. They should be identified by individuals in the community. We should be speaking with women and youth, and young women and children, and understanding really who are those different sources, and we can map those out easily. Ask questions in ways which fuel solutions. Ask questions in a way that when we collect data, we can use that data. We know how we can use that data. We're asking it in a way that ensures that we're involving the right people when we create the tools to do so. We collect data only when necessary. We use the data we have, so we know things on trusted sources. We know what are the key questions. We know how important it is to have skilled response teams. So are we already acting on that data? We need to monitor the potential impacts on health via secondary indicators, so like health services use should we continue to monitor. School attendance, all kinds of data that can be used as secondary indicators to monitor impacts. And we really do need to ensure an integrated and multidisciplinary outbreak analytics approach. So looking at data holistically, looking at misinformation or infodemic, looking at EPI, DHS, and saying, here's all the things that are happening. How are they feeding into each other? And how do we use this to better respond to the outbreak? So those are links. Everything we do is online, all of the trainings, tools, any survey tool, any questionnaire, any published stuff, it's all online, open access. You're welcome to use it. And I'll stop there.